I'm Joe. Oh, I want to hide that for myself. There we go. I am doing the visual diagnosis thing. A quick plug for anyone who is interested in getting involved, especially since I am now in my final year. It seems like this has been fairly well received, and there is openness to having it be longitudinal. So if anyone wants to take these slides and keep it going after I move on, I would love that. Stop with any questions or discussion you might have. This is meant to be a quick sort of hallmarks discussion, not an all-encompassing review of all of these things. So, and obviously, as always, I can't see the chat. So if anyone wouldn't mind being a watchdog on the chat and stopping me, and I will get started. So I guess if people want to yell stuff out, you can, but I think it just seems like with Zoom, it doesn't work as well. So maybe I'll just give everyone a minute to internally shout out what they think it is, and then I will reveal it. All right, so here's a patient. That is a leg. What do you think? All right. It is necrotizing fasciitis. Big things that you should be seeing here to make you think about it. It is not always, first of all, as obvious as the med school textbooks would have you believe, but the sort of red flags that you will probably be seeing one or more of is incredibly edematous. That one's kind of a gimme. You might see erythema. How do you say that's not cellulitis though? Big stuff is bullae and sort of bullous type changes. Obviously crepitus clinically, you should be really worried if you feel that. And the patient looks systemically horrible. Like they look really sick. Hemorrhagic changes like you're seeing there, other concerning findings, and obviously rapid progression. So if they say I had nothing there yesterday and it looks like this today, you should be really quite worried. The main treatment is emergent surgery, of course, but the temporizing measures are obviously resuscitation as usual, vancomycin, pseudomonal dose, and clindamycin, because there's also a belief that there's some toxin-mediated stuff. So you want to get your gram-positives, your gram-negatives, and your anaerobes, plus the protein synthesis component for the clindamycin. So that's the thought process there. All right, what are we seeing here? This should be a quickie. Not too fancy. Don't forget, I'm going to throw in some nuts and bolts, basic bread and butter EM stuff too. That is conjunctival pallor. This patient probably has a hemoglobin in the range of 6 or so. Everyone, in my opinion, who you're thinking about GI bleed or some sort of hemorrhage, one of the first things I personally like to do is to do what this person here is doing and just yank down the eyelid, and you'll get a ballpark idea of how low they're probably going to be. All right, what are we seeing here? If anyone says amputated finger, you're correct, but not what I'm looking for. All right, all the other digits, you are seeing pretty good amount of clubbing, which I feel like is another sweetheart of medical education that we don't actually use clinically that often, or at least I don't. Some kind of interesting stuff is, there's a name for this angle on the fingers, but the long story short is if they hold the two fingers together, I don't know if you can see on my camera, you should see a little gap between at the nail bed. And if you don't see that, there's at least probably a little bit of clubbing. It can be a congenital thing, but usually it's a systemic cardiopulmonary problem, notably not COPD classically. And interestingly, if you see it on just one extremity, there's probably a vascular malformation on that extremity causing it. So just sort of an interesting tidbit I learned. All right, what are we seeing here? And there's a broad answer and then a more specific answer that I'm looking for, specifically on the lateral view. All right, if you said pneumonia, you are correct. There's a consolidation there on the left side. Interestingly though, you can get even further. I would argue that you have a very crisp left heart border here. So it's probably more of a posterior finding, not abutting the cardiac silhouette specifically. And if you look on the lateral view, there's pretty tough to see the spine here, which I wish I put a clean lateral next to it for comparison, but this is a pretty good example of a spine sign, which means that there's probably an inferior lobe consolidation, which is essentially obliterating the projection of the spine. All right, what are we seeing here? Painful. That is herpetic Whitlow. Pretty common stuff. The classic board patient is like a dentist or something who took care of someone who had a cold sore. This is HSV, obviously, has that classic herpetic look, kind of dewdrops on a rose petal kind of thing, vesicular lesion. It is typically self-limited. If someone is really sick in terms of, immunocompromised chronically HIV, or they're on one of those MABs or something, you can give them acyclovir, but typically it's not necessary. The biggest thing to tell these people is to keep it covered, throw some bacitracin or something to help prevent secondary infection, but keeping it covered will help prevent the viral particles from shedding and spreading. All right, what are we seeing here? Give you a few seconds. All right. And also let me know if I'm going too fast, guys. So this is SVT, specifically AV-NRT if you want to get fancy, which is the most common form of SVT, which we kind of use just sort of as our catch-all vernacular. So the tips to think about this, and I think actually Otis mentioned a similar thought process, is fast or slow, narrow or wide, regular or irregular. And that gets you to a pretty narrow differential pretty quickly with these EKGs, in my opinion. And a couple of nice little tips that can get you there specifically to make this diagnosis are, first of all, you can't really see any clear proof of a P wave anywhere. But if you look closely, especially in leads V1 and 2, I could convince myself that I'm seeing retrograde P waves there, especially in V1. I think it's pretty convincing. The classic term for this in this situation is a pseudo R wave, because it sort of has that appearance to it, R prime wave, excuse me. Other things that are actually suggestive of SVT is QRS alternans, which I think you can appreciate in the rhythm strip here. Sometimes you can think, oh, maybe it's just, artifact from the patient breathing or something, but, and you might say, oh, well, how do I know this isn't tamponade and that's not electrical alternans? The important point to make is look at the QRS amplitude here. Because it has the same appearance in terms of the slight variation in QRS amplitude, but all of them are still within normal size. If this person had tamponade with electrical alternans, they would have low voltage due to their huge effusion. So that's another way you can kind of pick out whether you're looking at a conduction problem versus a physical problem causing this. So treatment, of course, as we all know, typical SVT treatment for these folks, adenosine, shock them. Some people are doing nodal blockers, pick your favorite. All right, what is this physical exam finding? Be quicker with this one. That is erythema nodosum. I feel like we talk about that a lot, but I personally don't diagnose it clinically too often. Take-home message for this is it is a symptom, not a diagnosis. So when you see that, I mean, there's a lot of classic associations, things like autoimmune disease, sarcoidosis, things like TB, infectious disease can do it, various vasculitides. So when you see that, you should be thinking about why are they getting this, and more looking into that problem. Typically, it's a self-limited problem that resolves within a few weeks specifically. And it's, like I said, more important to just figure out why they're getting it and ensure that there's not a sort of undiagnosed autoimmune disease or something to that effect. Specifically for the erythema nodosum, which is painful, it's kind of RICE therapy, pain control, elevation, rest. All right. That is not a worm, but what is it? Kind of looks like something from Tremors. You guys remember that movie? All right, that is phimosis in an uncircumcised penis. The biggest question for these, when you see this, is often they'll say, that maybe they can't, it hurts or they can't pull their foreskin back. But the big question that you should care about, which I think was actually brought up the other day by Lockhart, is making sure they can pee and they don't actually have urinary retention, which is sort of the biggest problem with these, is obstructive uropathy. So ensure that they're emptying, make sure that they're urinating okay. Assuming that is the case, then the treatment is basically topical corticosteroids, and especially in adults, this sometimes comes along with balanoposthitis, and make sure that they are either an poorly controlled or maybe undiagnosed diabetic, and maybe check a finger stick on these folks, because that can sometimes be associated. If they're stable and they make sure their glucose is under control, then topical corticosteroids in urology follow-up is fine, and maybe some gentle kind of foreskin retraction practice. If they are retaining urine and it's more of a pseudo-emergent problem, then you can do a penile block and essentially, once they're blocked, get some Kellys and physically just sort of spread, almost like you're opening up an abscess or something. That'll kind of loosen the foreskin enough that should relieve the urinary retention. And once that's done, you can put a Foley in, and they need urology more urgently. And I assume they do a circumcision, but I don't know that for sure. All right, what are we looking at here? That is a hypoglossal nerve palsy, specifically on the left side. So this is one I think sometimes gets tripped up on, is you would think, because going to left, you would, oh, maybe the right side is the problem. But in fact, actually, the problem is that the left hypoglossal nerve, so the muscles of the tongue, are so weak that they lack any tone, and all of the force and strength from the innervated side actually pushes the tongue toward the affected side. So this patient had a left-sided, ostensibly brainstem stroke. What are we looking at here? This is a light bulb sign showing a posterior shoulder dislocation, which are sometimes tricky and subtle and hard to catch, especially on the AP view x-rays. Some signs you can see, though, in addition to this, like, oh, wow, this kind of looks like a light bulb, is the distance from the medial aspect of the tuberosity on the humeral head compared to the medial aspect of the glenoid. On a normal here, you can see it's pretty close. It seems like it's well articulated, but if you look closely and you actually pay attention to it, depending on the angle of the x-ray shot, you might say, man, it seems kind of far from the glenoid to the humeral head, which can be another kind of suggestion that maybe you have a posterior dislocation on your hands. And this is just a plug to make sure you get that scapular Y view here, because that is classically the more important and useful radiographic image to prove your suspicion of a shoulder dislocation posteriorly. And if you want to reduce it, there's a bunch of ways to do it. I'm not going to waste time too much doing this, but essentially you're seeing axial traction, some internal rotation, maybe a second helper physically anteriorly manipulating the humeral head, and some counter traction. I will say it can be done with fewer people as well. And then they get a sling. You should consult ortho because these are more rare, and usually there's another abnormality in the majority of cases, but often these people go home with follow-up in a sling, just like any other shoulder dislocation. All right, this is funny, actually. I saw a case of this just a couple of days ago, but let's give you a second and see if you, I actually did not diagnose it despite having made this slide right up front. Other than god-awful looking, this is erythroderma. Again, this is just like erythema nodosum, more of a symptom of an underlying problem rather than the problem itself. The classic thing you're looking at is this kind of this scaly, peeling looking thing with significant erythema. And typically it's a very large body surface area. So I saw actually a little girl at Hasbro who had this on her entire body. She looked horrible. She actually ended up in a trauma room. And for her, we actually had derm come in. We even called burn because she looked like holy hell. And she did okay, thankfully. But so derm said that actually in her case, they thought it was severe atopic dermatitis, actually. That was what they thought caused it for her. But the classic kind of boards association is mycosis fungoides is another kind of classic cause of erythroderma. But in terms of your thoughts, it's more resuscitation. A lot of times it's just like any other burn. Fluid losses can be a problem. Pain is a problem. But it's more important beyond that to figure out why they have it. So it's more of a diagnosis of underlying cause is your bigger thought on these folks. All right, this patient is a level C. The nurse says, can you look at the x-ray before they go to CT? What do you think? No, they cannot. They have a large hemothorax. Which side? I'll give you a few seconds to decide. The right side. much more, not echogenic, this is an ultrasound, much more radiodense on the right side here relative to the contralateral lung. And because you're seeing plenty of lung markings going all the way out on the left, you know it's not a pneumo on this side. Hence, there must be some sort of effusion on the right side. And in the setting of a level C, it's probably blood.